Hi everyone, I'd like to tell you a little bit about immunization supply chain interventions that enable coverage and equity and contribute to resilient systems. So if we go to the next slide and we look at the backdrop of disrupted services due to COVID-19, the WUNIC 2019 data shows continued stagnation. So almost 9 out of 10 children have been reached in 2019, but that still translates to almost 20 million children un- or under-vaccinated. And in the next slide, we also see the impact of COVID on immunization, on Penta-3 coverage. So in Africa alone, approximately 1 million children less were vaccinated this year compared to last year. And that means that translates to 20 countries that have more than a 10% reduction in the number of vaccinated children, either for DTP3 or measles-containing vaccine for the first half of 2020 compared to the same period in last year. In the next slide, we see that immunization campaigns were also disrupted. And I think the map and the table gives you the details. But the headline is that 48% of measles campaigns in 25 countries are still being postponed due to COVID. And this translates to 74 million people being affected. Next slide. WHO and UNICEF continue to advocate, and this is through global guidance, joint statements, etc., on the continuation of immunization activities during the pandemic. And, this is incredibly important to reach the underserved communities. I also want to take a little bit of time, and this is in the next slide, to tell you a little bit about the Equity Reference Group. So they're looking at reaching the most marginalized communities. And in the next slide, we see how immunization coverage has improved, but then stagnated over the last couple of years. And we can see that we have continued, we've struggled to reach the last 15% of children. So despite this progress, it's the same populations and the same communities that are not being reached. And we know almost nothing about these children. So we don't know their name, the date of birth, sex, where they live, their vaccine doses given, mother and father's names, or even the total number of children who we've missed. In the next slide, we also see that data on coverage rates is generally aggregated. So on the left-hand side, we see that the national aggregated data masks disparities in access both between and within countries. As shown here, looking at the national figures in Africa doesn't present a full picture of the critical differences in coverages that exist. We need to look at more granular data, as seen on the right-hand side, to see pockets of consistently missed children. In the next slide, we see that the ERG has identified 4 priority areas of immunization inequity. So it's remote rural areas where it is difficult to access children. Also urban poor areas where children are sometimes very difficult to track. In conflict areas where it's dangerous or impossible to send vaccinators. And then gender emerged as a cross-cutting theme where mothers are often the primary caregivers and cultural roles often heavily influence health and decision-making in the home. In the next slide, you can also see that the never reached children mostly live in Africa. The African region and countries affected by conflict are home to large numbers of these so-called zero-dose children. And I think the figure and the graph are very telling as to where these children are situated. In the next slide, I want to tell you a little bit about these contexts. and describe them a little bit for you. So in terms of the urban poor, there's a lack of accurate and disaggregated data, which creates difficulty in tracking these populations. There's cultural differences, which creates social distances. There's the quality of services and lack of information impacts access to immunization services. There's a lack of political will to prioritize services. There's also a fear of public authorities. There's a lack of effective partnerships, and insecurity and violent crime restrict access as well. In remote rural, the marginal cost vis-a-vis the low population density makes the costs of reaching these populations high. Staff retention and motivation is also impeded by the resource limited environments. It's also geographically difficult to reach these really remote areas. And these areas also have limited socio-political power. And then weak data also produces an incomplete picture of these areas. Conflict, I think, is also creates a very clear picture. There's damage to infrastructure and supply chain, difficulty retaining health workers. I mean, who wants to work in a war zone? Delivery of services is really challenging, mistrust and population displacement and migration. So in the next slide, we've tried to figure out, together with the EPI program, what are the cross-cutting levers in your supply chain which can be implemented together with the operational strategies. So one thing is your forecast, increasing buffer stocks in targeted areas and adjusting your forecast to accommodate variations in target populations across these three settings. Stratified budgets in each setting to ensure sufficient funding to meet the unique requirements of each setting. Controlled temperature chain, alternative vaccine presentations, utilizing smaller dose per vial presentations to encourage health workers to open that vial and prevent missed opportunities where target populations are small. Cold chain capacity, so optimizing vaccine carrier and cold box carrier capacity for transportation and session sizes. Cold life or cold range of passive devices, and thereby improving the range of passive devices to reach these target populations. Supply chain design, optimizing to prioritize coverage and equity ahead of the usual efficiency indicators. And then finally, and very importantly, integration of both services and commodities into EPI. In the next slide, we look at remote rural contexts. The coordination with other programs becomes critical. Community-based involvement, looking at cross-border teams, the use of long-range passives, availability of mobile storage units, and adequate storage capacity to accommodate buffer stocks, all really addresses the challenges of remote rural contexts. In the next slide, in the urban poor context, integration of services, a focus on solarization and larger storage capacity, partnerships with the private sector, system design to include increased distribution points, adaptation of health facilities to the context. So for example, flexible opening hours to provide opportunities for working caregivers to seek health services helps to address the challenges specifically in urban poor areas. In the next slide, we look at the conflict context. So resiliency in the supply chain, the use of temporary storage sites and long-range passive containers for hit and run teams that are particularly used in the polio programs, partnership with military agencies, shockproof passive containers. In the next slide, we've provided a link with the pro-equity strategies, and there's a link with the supply chain strategies that can be found there as well. So in the next slide, in conclusion, what I'd like to say is that COVID-19 has provided both the opportunity and the necessity to push for real integration between the various immunization activities and into primary healthcare for the most underserved, both at global level and at the implementation level. The need to deliver services in a safe manner through a human-centered design could enhance quality of services and enhance service experience and trust. The Immunization Agenda 2030 provides a framework to structure this under and including linkages to primary healthcare and universal health coverage. The cost to reach zero-dose children will be more and needs to be considered in the budgeting process. And finally, supply chains need to be designed to maximize programmatic outcomes. With that said, I say thank you very much.
Okay, thank you very much. This is from Pakistan, and we're looking at how immunization supply chain interventions are able to enable coverage and equity, and want to share little of the Pakistani experience and how our intervention has improved equity and coverage. Together with me on this presentation is Naeem Asgar, is the Director of Operations in the Federal EPA. Yeah, we had 4 major interventions that we use in reducing inequity in Pakistan. The first was the CCOP, which we started implementing in 2016-17. The second was the system design. The third was through the urban profiling. And the third was the equity analysis of districts with the highest number of zero dose, and how we were able to use a supply chain to improve coverages in those areas. However, the first two are direct intervention using supply chain, while the other two are somewhat indirect. But we'll look at the details as we go along. Yeah, while we were preparing for our CCOP, one of the major considerations and what we use in prioritizing our allocation of equipment was looking at which areas have the least coverage for immunization. That is, which of the district has the least coverage or coverage is less than 50%. And when we identify all of them, there were 65 in numbers. And on further analysis, we observed that about 1 million children in these 65 districts were unimmunized. And that number was about 30% of the total bed cohort in those 65 districts, which was very substantial. So what we did was to analyze the gap, the cold chain gap for these 65 districts. And that was our first priority when we implemented the CCOP for year 1. And maybe I should say that our CCOP was implemented in 3 phases, in 3 years. We have only completed the first, and we are concluding on the second phase. We still have 1 phase to go, which will be implemented in 2011. Now, after analysis, we discovered we allocated a total of 1,031 coaching equipment to those 65 districts and 857 facilities that had coaching gaps. So that was the first step we applied in addressing equity, because we felt that if coaching equipment are available and vaccines are available to those locations, then the number that can be reached will also increase, thereby increasing coverages and equity. So that was our first priority. That was the first thing we did. Now the second was using system design and how we use equity consideration, how we applied equity consideration in the system design. Now, generally, equity is not a major consideration for allocation of resources in government. The government tends to look at the highest place, highest number, highest population where they can make impact. In addition, existing facilities are given priorities over equity Implication is that the same target are reached with services all the time, while the same number of children are missed out. Coaching equipment allocation was prioritized for existing equipment. In addition, from the system design study, we were able to observe that coaching per infant is relatively high, but moving storage closer to service delivery point could help in alleviating geographical barrier to vaccine availability, such as distances and so on. Distances to supply, to resupply locations and so on and so forth. Then this is so because coaching equipment are concentrated in urban centers and placed within average to high population densities. That is usually population densities are prioritized. Those are the traditional way of allocating coaching equipment. Look at where the highest impact, the highest number of children will be reached. Areas of sparse population are usually not considered and left out. Now, how did we apply equity in the system design? What was our consideration? We looked at it from 3 angles. We looked at the cold chain coverage. We look at liters of cold chain per surviving infant, estimated birth cohort, surviving infant, and so on. That is, what was the capacity required to fully immunize a surviving infant? That was one of the considerations. The second was we looked at inbound resupply distance of vaccine to district store. That is kilometer to district store from the store from which they receive vaccines. Then we also looked at kilometers traveled by each dose to EPI centers from the supply store. So putting all this together, we use that as a parameter. We derive some indicators for which we measure whether a district or a facility need to be prioritized or not. Now, those are the 3 areas that we use in our modeling. The first one was the definition of that is cold chain storage, and I've already defined that. And when we did the analysis using EVM assessor tool, we observed that we needed, for a fully immunized child, 0.06 liter capacity was required. And that was one of the parameters we used. And why visualization, we agree that what capacity that are greater than 0.9 will color green. While capacity between 0.09 to 0.9 will be at the middle, which will be yellow. While whatever is less than 0.6 will be red. That is a 0.6 liter for surviving infant. The second consideration, as I tried to explain, was the distance from resupply point. Now for the district store, we saw that the average kilometer, 120 kilometers will be required for somebody to travel from one district to the supply point and return the same day. So for district, we applied 120 benchmark. So, and for visualization, we categorize any kilometer less than 90 as green, between 90 and 120 as yellow, and greater than 120 as red. Therefore, the same thing was applied to the facilities, that is the EPI centers. But in this case, the average distance for facility personnel to travel and return the same day for collection of vaccine was 60. And for visualization, we use less than to be green, between 45 and 60, yellow, and above 60, green, the red. Now, we also know that consideration for equity is not only vaccine, other things also comes to play. Then we also apply the coverages, immunization coverages, the range, because we use all this information to develop a map to see where each of these fall in, to be able to identify which of the percentile we had less coverages and so on and so forth. And we also look at the women socio-economic status, the women with primary school education and so on. And we categorize them according to this color, 90 to, according to the color and the figure and what you have seen on the group. Now, how did we apply this? Now, when we combine the coaching capacity per surviving infant against immunization coverage using the percentile that we have in the previous slide, we had this picture for the 4 provinces that we had. And we're able to deduce that to some extent, high immunization coverage, like the first group we had on the top right left-hand corner, we saw that high immunization coverage and low coaching coverage was what was significant in the top left-hand corner. So in other words, some facilities still had high coverage even when the capacity they had was not adequate. Then we also observed that some also had high immunization coverage and high coaching coverage, while some had low immunization coverages and low coaching coverages, and low immunization coverage and high coaching coverage. So what we decided to do was to at least address the locations that have low immunization coverages as well as low coaching coverage. So we prioritize those districts. Because we observe that supply chain intervention is not the only parameter that improve overall coverage for immunization, from what we have seen even from this graph. So we decided to at least improve the low coverage that will contribute to availability of vaccine in those areas. Then other considerations can come in to improve the overall system. So that was one of the applications. The second was using the resupply distance to health facility against full dose of penta vaccine. And we still have the 4%. And we saw that, and I should say, even in the previous slide, we observed that it is most of the high density population are the ones that have high immunization coverage, even when the coaching capacity was not adequate. That was one of the findings from this study. Then on this map, we looked at the weighted resupply distance to health facilities against 10 dose pentavalent coverage for the provinces, for the 4 provinces of Balochistan, KP, Punjab, and Sindh. And we also saw that in the towns, in the district that are within high population density, where the distance for vaccine collection is very short, they have very high immunization coverage, And we also observe that in some locations, even when the distances were longer, immunization coverages were also high. And those areas are also in some of the highly population provinces. Then we observe also that in some of the provinces, they have low immunization coverage and shorter distances, while some have low immunization coverage and travel longer distances. So what we use this information for was to at least shorten the distances for those districts and facilities that we have identified that have low coverages, to make vaccines closer to them, as that may impact on the access to vaccines and probably increase the coverage for those locations, for those facilities and districts. Now, when we put all those information together, we apply this to every district in the country. We apply this parameter to every district. We're able to pick out which district we need to prioritize. For example, in this group, the second, the inbound supply the inbound supply distances to vaccine locations was one of the major impacts for this. And we picked these districts. Batagram district is one of the districts in KP. So we observed that for this district, reducing the resupply distances, we improve vaccine availability to those locations. So that was one of the areas how we use this information from our system design to improve, at least make vaccines available to facilities and province and districts. For this scenario, for example, reducing resupply distance of district store will improve reliability and responsiveness of vaccine supply chain and contribute to improve immunization coverage. In addition, this was applied also to health facilities and guided prioritizing locations for our year 3 allocation of coaching equipment. And what was the overall, how do we apply this overall? One, the province provision of coaching equipment, we prioritize those district and health facilities that have long distances and low coverages for coaching allocation. Then some of them, we had to change their source of vaccine supply. Traditionally, the vaccine supply to facilities or the district will come from its province. So what we did, because some of the distances were very far, so we changed the supply route. Some of the districts were now collecting vaccines from another province other than their own. In addition, some of the facilities are now collecting vaccines from another district other than where they serve. However, in the VLMIS, the allocation is reflected as the district where they belong, because it's like the other facility keeping vaccines in another location. So those was why we apply our system design to change the delivery route and the resupply route for some of the districts and some of the facilities in order to improve, to shorten the distance traveled and make vaccines available.
So thank you very much, Mr. Kilobo. Yeah, it was a collective work, and I think it's a very nice presentation by you. So just to add in that, because now we are at the time of implementation for the phase 3 of CCOP, which would be the final phase of CCOP, through which we would deploy about 3,350 equipments. And we worked very hard with the support of UNICEF and in consultation of the provinces and areas in Pakistan. And we allocated more than 50% of the equipment from phase 3 for new health facilities, as Mr. Kilobo explained, considering the distances, considering the equity, and considering the rationalized distribution of the health facilities throughout the country, so that the accessibility for the immunization services and to increase the coverage at fixed site, to rationalize the resources of immunization as well. So by implementing CCOP this year, so this would contribute a lot to increase equitable access throughout the country, throughout the Pakistan. And it would increase that equitable access for the community to reach out the immunization centers or fixed site to get their children immunized. And it would also, by making these health facilities and providing coach and equipment, so it would increase HR. It would also help us to make more micro plans and then more outreach sessions as well. So definitely it would contribute to contribute to increase our services, immunization coverage, and to eradicate polio, because unfortunately Pakistan and Afghanistan are polio endemic country. So there are a lot of reasons, and one of the reasons is accessibility is so we would also try to cope up that problem by distribution, and by doing all of these immunization supply chain interventions, by considering all of these challenges and gaps which we identified in immunization supply chain system design study and this urban, prioritization. Over.
So thank you very much. That is all from us.
Yes, thank you.
So my name is Haji Radara. I'm the Director of Logistics and Health Commodities at the MPACDA Nigeria. I'm here with some members of my team. I'm here with pharmacist Bello Abdul Kadir. He's a Deputy Director in the department. I'm here with Dr. Onome. She's with UNICEF. Dr. Ahmed Issa is here. He's with WHO. And then pharmacist Awatensi is also here. She's the head of operations in the department. So on behalf of the team, I'll be making a presentation on immunization supply chain interventions that enable coverage and equity and contribute to resilient systems in Nigeria. So Nigeria's immunization supply chain transformation strategy is aimed at providing equitable access to immunization, of course, so that we can increase our immunization coverage. So in Nigeria, we have all the different types of settings that have been said to us. We have places that are affected by conflict, like in Borno and Zamfara. So what we have done in conflict areas is, because the places are security challenged, we have involved the army. The involvement of the army is not only to deliver the vaccines, but also to keep the vaccines safe. So we are using their storage facilities to keep our cold chain equipment and also the vaccines, as is seen from the picture. So down there, we also have the urban slums, like in Lagos and Kano. This is actually a picture of an urban slum in Lagos. Those people that are paddling the canoe are going for routine immunization services. So they go by canoe to make sure that they reach every single child, because we don't want any child to be missed. Then the other picture there is showing a place in Sokoto. So the place too is riverine, and he doesn't even have the luxury of a canoe. So what he did is he has improvised one for himself. You can see his geostyle there and the syringes. He's going for an outreach session. Of course, the gender is all over the country. We make sure that we reach women with TD and also the children too with their RI. So as a background, Nigeria has a 5-tier immunization supply chain structure. We have the national level, where we keep the vaccines at the National Strategic Cold Store, which is based in Abuja, the capital of the country. We have 6 zonal cold stores spread across the 6 geopolitical zones of the country. So from the national level, at the National Strategic Cold Store, we push vaccines through the zones to the states. Now from the states, we are this 36+1 states now, the architecture for the supply chain is different. So some states use a push system. They push to equipped health facility. We have over 30,000 health facilities in this country. So some of them have cold chain equipment, which will be explained later. Some do not have. So those that have cold chain equipment, we have designated them as apex health facilities. The states push the vaccines to them. And then those that do not have cold chain equipment, that is the unequipped health facility, we call them cascade facility. So depending on how strong the state is, some states, the unequipped health facility collect vaccines from the apex health facilities. In some states where the state is buoyant enough, they fund the pushing to the unequipped health facilities. And in addition to this, for every level of the supply chain, we have a logistics working group. At the national level, we have a national logistics working group that meets 3 times every week. The national logistics working group consists of the government and all the partners that are working on logistics in the country. Under the national logistics group, we have the zonal logistics working group. Before, the zonal logistics group was comatose, but we've been able to reactivate this zonal logistics working group by engaging people that we now call supply chain experts. So they make sure that there's an active zonal logistics working group in place, and then under them, they have the state logistics working group. So now it's easier for us at the national national level to manage the state logistics working group, because we have 37 state logistics work, so it hasn't been easy for us to manage them. But now with an active zonal logistics working group at the national level, we only have to deal with 6 zonal logistics working groups through zonal liaison officers that are based at the NLWG. Now, equity. What have we been doing in terms of coverage and equity? Our immunization supply chain is suboptimal to respond to our programmatic needs, but we've been doing a lot to address this so that we can have coverage and equity in the country. From the national level to the zones and the states, we have outsourced the vaccine delivery with long-term agreements. So even the maintenance of the cold rooms and the maintenance of the generators that have to run to maintain the cold rooms has been outsourced. Like I was explaining earlier, there are 8 states that do direct vaccine delivery. So these 8 states have state satellite stores. Most of these states are states that are under the MoU, Memorandum of Understanding. So they have satellite stores, some have 3 satellite stores, some have 6 satellite stores. So these satellite stores deliver vaccines to the apex health facilities that I've explained earlier. These are facilities in the wards that have cold chain equipment. And then the cascade health facilities that do not have cold chain equipment they either go and collect vaccines from the apex health facilities, or the vaccines are pushed to them, depending on the listing. So each of the catchment areas has either an apex health facility or a cascade health facility. Now, the NLWG ensures that there's availability of potent vaccines in security compromised and hard to reach areas. For example, Borno and Yobe. This we are doing by collaboration with the military, as I have explained. It's not only that the medical corps in the military go out and do the immunization for us. Sometimes it's a fixed session. They come when it's time for fixed session to guard the people so that the militants do not come and attack them. Sometimes, and then a lot of times, we have to keep the vaccines in the military cantonments. Some of these military cantonments contain our cold chain equipment. We also make use of active and passive devices that have long holdover periods. And then oversight is provided by the National Logistics Working Group at the national, zonal, and state level. We have a dashboard which the 774 LGAs and the 37 states populate every week. This we are doing through ODK for now, but later we are going to have a more robust LMIS. But for now, we are using ODK while we are still in conversation with Gavin for development of a more robust LMIS. And on a weekly basis, the national and the zonal looks at the dashboard and look at the stock level to mitigate stock out. And then you find that regularly we are doing redistribution of vaccines. Where there is overstock, they take to places that are stock out so that there will always be availability of vaccines for coverage and equity purposes. That intervention we are doing to address coverage and equity issues, because we know we have inadequate storage capacity at all levels. And the policy of the country is to have at least one functional vaccine refrigerator per ward to provide equitable access to vaccines. In Nigeria, we have 9,656 wards with over 30,000 health facilities. So the NLWG has developed a cold chain expansion and rehabilitation plan. This plan is updated on a quarterly basis. So the data is sent by the state so that at any point in time, we know where we have functional cold chain equipment, we know the storage capacity and other parameters like that we need to know. In addition to that, we have procured additional cold rooms at the national level, and each of the 6 zonal stores were given additional cold rooms. And then our long-term plan is to have 3 mega hubs, one in Abuja, one in Lagos, one in Kano, and plans are at an advanced stage to establish these 3 mega hubs. Some states too have not been left out in procurement of cold rooms for their state cold stores. Borno has procured, FCT procured, Kano procured, Katsina, Lagos, Sokoto, and Zamfara. We are also leveraging on the cold chain equipment optimization platform. When we're submitting this CCOP application, what we put in the front banner was to address coverage and equity issues. So our selection was based mainly on coverage and equity. And this will go a long way to close all the gaps at the LGA and the world levels. And this support is going to last up to 2028 in line with our NCIPS document. So all the cold chain equipment in the country are equipped with RTMDs to monitor equipment performance and proactively trigger maintenance activities. In addition to that, before we started deploying equipment under the cold chain equipment optimization platform, all the 36+1 states established maintenance units. And these maintenance units have at least 2 trained technicians that are being trained on a regular basis and are equipped with the necessary resources. So how are we addressing resilience? So in 2017, when our new executive director came on board, he decided to accept the 2016-2017 NICS mix because there was a wide disparity between the national immunization coverage of that survey and the admin coverage. While the admin coverage was saying we had a coverage of over 100%, the NICS mix was saying that our coverage was 33%. And then we found that there was a large variance between the lowest performing states and the highest performing states. A state like Sokoto had coverage as low as 3%, while Lagos had coverage of 80%. So what did we do about this? In addition to setting up a National Emergency Routine Immunization Coordinating Center, which was meeting on a daily basis and working out strategies to improve the immunization coverage in the country, NLWG, that is the National Logistic Working Group, also swung into action. We said, okay, there's no need for us to be calculating a coverage of 80% for every state in the country, when we know some states were having a coverage of 3%. So we decided to be doing state-specific forecast. So for each state, now after that, the NCIPS document was developed. The NCIPS document did modeling, and there was coverage projections for each state. Now the states were categorized into 5, low 1, low 2, low 3, medium, and high. So the NCIPS, that is National Strategy for Immunization and PSC System Strengthening, is from 2018 to 2028. So we are based on this document we are using now as a guide in the country. So the states had been categorized inside. So what we do now is a state-specific forecast. States in low 1, what has the NCIPS modeled for their coverage for the next year? So we do their forecast based on that coverage. And then to mitigate stock out, what we did is we now looked at the buffer. Instead of saying, okay, all over the country, we are going to forecast a buffer of 25%. We said no. For states that their coverage is less than 60%, let's project a 50% buffer for them. This will mitigate stock out. And then for states that their coverage is greater than 60%, we are using 25% coverage for them. For the wastage rates, now it's country specific. Some of the antigens we are using WHO indicative wastage rates, but for some of the antigens now, we have our SMS data that we are collecting on a daily basis. Immediately the healthcare worker finishes immunization, they send the SMS data to us. So based on that SMS data, we now looked at it. And so for some antigens, we have country-specific wastage rate that was calculated. We started the state-specific forecast in 2018. In 2019, we had an engagement with the states. At this engagement, we reviewed the forecast parameter vis-a-vis consumption and the physical stock counts that we carried out. And one thing we have found with this state-specific forecast is that it has gingered the states now. And we found that the immunization coverage is much better. So we're also in the process of reviewing and updating the vaccine management standard operating procedures in line with the EVM 2.0 guidelines, because there were some things that were not in the traditional EVMA that are now being included in the EVMA 2.0 guidelines. So we're in the process of reviewing and updating the vaccine management standard operating procedures. And then we're also developing Nigerian immunization supply chain policy because we found that we do not have one. What we have in the country is an immunization policy, not an immunization supply chain policy. So in conclusion, what we have found is that all these supply chain interventions have contributed to a large extent, in addition to other things that the program is doing. We have found that it has produced an improvement in RI coverage and equity while building system resilience. If you look at this graph, you find where we have gone from our 33% in 2016. Now we have doubled, and now we're at 67%. And these are not administrative data. This data is from surveys that were conducted by independent people.
Okay, good morning, everyone. Today we are going to talk about the immunization supply chain in Afghanistan, and the presentation will be done by me. I'm Dr. Nadri, the National EPI Director at the Ministry of Public Health of Afghanistan, and my colleague Ranjit, Immunization Specialist Supply Chain in UNICEF Afghanistan Country Office. So basically, the country background we are going to talk about is, right now what we have is 35 million population as per the UN estimates, and we have 34 provinces. In 34 provinces, we have 3,500 health facilities, out of which 2,200 are providing EPI services. We have a package of health services which is contracted out in 31 provinces to the BPHS implementers, to non-governmental organizations. In 3 provinces, it is contracting in within the Ministry of Public Health. We have colleagues. The entire package of health is funded by the World Bank, Gavi, Government of Japan, Gates Foundation, UNICEF, WHO, and USAID are basically the donors for the entire package of health, which immunization is part of that. The challenges we have in the country is it's an polio-endemic country. We have low immunization coverage since almost 4 years, stagnating at 51% full immunized. And then it's insecurity and access to almost half of the country is the other challenge we have. The difficulty in geographical terrain is another challenge that we have. And since 41 years, there is no population census happen in the country. And unfortunately, the country is one of the country we have electricity issues almost in more than 70% of the area. Well, the strength point we have the vaccines availability and assurance in the country. There is strong supply chain we have, and we have a strong partner and donor support in the country. So basically, these are the points that we have in the country. What work well in the country? I think the supply chain in Afghanistan is one of the greatest supply chain in the region. We have done a temperature monitoring study as per the protocols of WHO in 2 sessions. It's in the winter season and in the summer season. It shows 96.9% in summer. The temperature was starting from the national level up to the outreach and mobile station. It's showing 96.9% between 2 and 8 degree temperature. And it was wonderful in winter, which shows 99.2%. So that is basically the biggest achievement and biggest work which is happening in the supply chain in Afghanistan. Well, we have half of the vaccines in the country, the traditional vaccines are funded by the government of Japan. And those vaccines are almost available in the country, and we does not face any shortage of any kind of vaccine supported by Gavi or by government of Japan. So here we are talking about this 5 fundamentals which we have in immunization supply chain, the supply chain leadership, we have planning and improvement. The 3rd fundamental is data management. The 4th one is we are having the cold chain infrastructure, and the 5th one is the supply chain optimization. Basically, these are the 5 fundamentals which the country is working on, and the vision we have is immunization supply chain is on the top agenda of the EPI management. We have good leadership on supply chain at the national and regional level. And the Immunization Microplan and Immunization of Action Plan is also the visions we have. The actions which is basically we are taking is establishment of national and regional logistic working groups, EVM improvement plan, and supply chain strategy as a guide for logistic working groups for annual plan and focus on the meetings. Basically, these are the actions that need to be taken, and the impact of that would be the focus on service delivery, equity, the vaccine delivery, cold chain for hard to reach area, and solution for persistent problems, and security logistics service delivery. So basically, we are talking about our visions and actions and impact, and on the basis of these 5 fundamentals, which I explained on the beginning. So here I hand it over to Ranjit to continue the presentation. Over to you, Ranjit.
Thank you, Dr. Nazari. So in terms of planning and improvement fundamentals, what we plan to do in the country is this is a good time to start the portfolio for next 5 years because there are several things falling in place at the same time. 2021 to 2025 is a time when national immunization strategy is being revised. This is the time when our funding sources, which is mainly Gavi, full portfolio planning is also falling in place. And so we just now concluded EVM assessment and the improvement plan. The vision is the improvement plan would contribute in implementing the supply chain fundamentals. And so the activities, fundings, everything within the framework of this supply chain strategy is included in our plan. So as Dr. Nazari said, the implementation action of this plan is eventually we will hand over the plan to each provinces and each region, to the logistic working groups of the region, and they'll be through the mechanism of our routine monitoring and evaluation, we'll be tracking the EVM improvement plan, which eventually delivers all the parameters of our strategy. And the impact is, in fact, everything falls back to the same window that, how are we improving the areas where we need to improve. 51% coverage is where we are reaching, and then we aim to add another 40% to that. And that 40% really comes from the area where we are not able to reach in Afghanistan context. So through making these plans and monitoring and evaluation, we are really trying to resiliate our supply chain and a tailored solution for hard to reach zones. Within the fundamental of data management, I think this is the foundation of any program. Quality of data, accuracy of data, and timely availability of data from all perspectives, whether it's a coverage data for making decisions on where we are, or it's a supply chain data to make to support our vaccine supply logistics, or cold chain information to see where we are in terms of strength of cold chain. We need to improve the data quality, and the vision is really to improve the data collection at source. And to solve this problem as a part of next 5-year plan, we are moving ahead with a mobile-based application platform, which includes data collection of all the fundamentals of supply chain and immunization, where we'll be collecting cold chain inventory through mobile application. We'll be collecting stock information. We'll be collecting coverage information right from the health center, and there'll be online dashboards, which provides us access to information to not only to limited people, but it expands to all the stakeholders, including donors. At any point of time, we are in position to see where we are in terms of data. So better quality data gives us option to improve other things where it's actually enabler of service delivery. We are in position to take informed decisions. In terms of cold chain infrastructure, as Dr. Nazari said, we already have very good infrastructure. Temperature monitoring study reflected the quality of cold chain, but eventually this is a continuous job and we need to improve. Part of the improvement plan is, of course, resilient cold chain infrastructure, including buildings for the provincial vaccine stores, regional vaccine stores, and the cold rooms, which are required to upgrade based on growing needs of the immunization program. New vaccine is introduced. So where we are today is good, but where we need to be after 5 years, that's also included in EVM IP, and eventually we'll be moving towards improving our infrastructure, which is not only cold chain equipment, but buildings, transport options, One of the finding of temperature monitoring study was eventually, transportation of vaccine is something we need to look at. We need to improve the quality of cold chain there. So we are also moving towards the direction of freeze-free cold chain. There is as a part of CCOP platform, we have options very soon available to go with freeze-free cold boxes and vaccine carriers. So all those is part of the infrastructure building. And eventually we also want to add the infrastructure for urban areas and hard to reach areas. These are out of the box additional solutions to reach those populations where we are not able to reach. So build the infrastructure for them. Coming to the last fundamental of immunization supply chain optimization, of course, what we have today, we need to improve on that. Part of the optimization vision is maintenance of temperature, continued maintenance of temperature and cold chain equipment, vaccine distribution networks to improve the supply and also address pandemic solutions. COVID is on agenda of every country now, and also seasonal vaccination to go hand in hand. So as part of the optimization is we are establishing maintenance center of excellence where all the in-country resources, human resources are trained on regular basis. Their capacities are upgraded to new technologies. We'll be using remote temperature monitoring for maintenance of cold chain. We'll be engaging with NGOs and private partners for service delivery, including urban and hard to reach. There'll be online, there'll be continued discussions with, let's say, the term here is anti-government elements, which is basically Taliban, and improve our collaboration for service delivery with them. So this is all part of the supply chain optimization plan. So how do we put this plan in action? What we have is we have a situational analysis where we are today. National immunization strategy is revised as of now based on the current situation, and our situational analysis is supported by EVM assessment as well. And then we have implementation plan, which is the bigger umbrella of under this comprehensive improvement plan. This plan will then be funded. We will be proposing to Gavi under full portfolio planning to fund this improvement plan and improve the immunization supply chain conditions in the country. I'll pass on to Dr. Nazari to conclude the session.
Thank you so much, Ranjit. Now what we are basically talking about is reaching the unreached population. So what we are trying right now and what we are doing is we have started the immunization microplan at the health facility level. Almost in across the country, we have to complete this. It's going on in almost 8 provinces of the country. So we are adding pool of vaccinators. We have planned IPC training and the community engagement through different sources and methods in the country. We have the community plus, community dialogue plus. We have the source of the CHWs. We are engaged them in the immunizations activities, and we basically create the demand through them. So on supply chain, basically we improved the access and leadership, cold chain infrastructure, as mentioned by Ranjit. Also, that's something that we are continuing on a continuous basis. We are doing that to be on the optimal stage for supplying the vaccines across the country. And quality data for continuous improvement is another thing that basically we are doing on the supply chain. So the result of all these, what we are hoping would be improved coverage. We are hoping that to reach those zero-dose children and zero-dose communities. Reduction of dropouts is one of the other results that we are aiming out of this, which is one of the biggest challenge of the immunization program in the country. The dropout rate between different antigens are very much high, and improved fully immunized coverage in the country, which is stagnating for almost 3 years, is what we are expecting to be as a result of that. And resilient system for routine and emergency vaccination is another thing that we are expecting to be happen. So with this, we end today's presentation. Thank you so much,